Good evening. Sorry for the delay. I just came back from my workplace. So today we shall be discussing about the part 3 and the last part of endocrinology, and it will be based upon diabetes. For diabetes, I have kept a separate session because diabetes can come in different forms. We shall be discussing almost all of them today. Where is it? Just here it is. I hope everybody can see my screen. And so we shall start. How many people are online? Okay. Dr. Latif, Dr. Amin, Dr. Ishani, Nusrat, Pratap, Rijoy, and Shiv. Dr. Shiv. Okay. I hope everybody can hear me and my screen is visible. So we shall be starting the class.
Yes, sir. Good evening, sir.
Good evening.
Yeah. So, all the aspirants, this is going to be an interactive session. Any doubt, any question, do put it in the chat box. And you can also unmute your mic. So, we are starting with the session. The topic for today is endocrinology. And we have Dr. Sangdhaptak Saha. He is a consultant critical care medicine at Apollo Hospital. Thank you, sir. You may start.
So, diabetes in MRCP can basically come as pictorial questions. It can come as like a diabetes as such, the management, the complications. It can come on the basis of like pictures of the retinopathies, diabetic retinopathies, along with hypertensive retinopathies, obviously. And it can come as medically or surgical emergencies, a diabetic fit, and that is ulcers and gangrene. And other than that, the different types of amyotrophy, neuropathy, the differences, and how to assess them, these things will be asked. And the bit upon the different management, the different insulin types and different hypoglycemic types. So first, the very basics. What are the pancreatic hormones? There are the two types of cells: the A cells, the which produce glucagon, and the B cells, which produce these insulin, C peptides, and the GABA. There are also cells like D cells, which produce somatostatin. So the glucose transporters are also basically questions. So they transport glucose actively against the concentration gradient. SGLT1, they are found predominantly in the gut and are responsible for glucose absorption. They are sodium glucose co-transporters. These are the ones which I am marking out. Those are the questions which have already been asked in the exam. Okay. So GLUT1, the GLUT1 and GLUT3, they continuously transport glucose into the cells. So they transport glucose into the cells. They are widely distributed, including the brain, RBCs, endothelial cells. So this one is important when multiple times asked. They are the ones which are expressed in the RBCs, that is mostly expressed in the erythrocytes. GLUT2 are present in pancreatic beta cells. So which are present in the pancreas? It is the GLUT2. So it is present in the pancreas, also present in the hepatocytes. It is a low affinity glucose uptake. So it is a high capacity but a low affinity. So these things are important. High capacity, low affinity. And these will be direct questions. High capacity, low affinity. It facilitates insulin release in the beta cells. So GLUT2, say these are the questions which can be asked in the exam. GLUT1, these are the questions which can be asked in the exam. Widely distributed, mostly in the RBCs. GLUT1, GLUT3 transport glucose into the cells. GLUT3 we already discussed. It is like GLUT1. So what is GLUT4? It is the only glucose transporter responsible to circulating insulin levels. That is the blood insulin levels and the glucose. Their relationship is controlled only by GLUT4. So whenever there is an increase in the plasma glucose concentration, there is an increase in circulating insulin, increase in the expression of the GLUT4. Exogenous insulin in the treatment of diabetes mellitus also results in via the GLUT4 co-transporter. So any insulin in the blood, whether it is the endogenous insulin or the exogenous insulin, will be taken up by GLUT4. Okay. So it is stimulated by exercise and basal level of glucose intake without insulin and insulin control uptake of glucose. So GLUT2 is the one which is present in the pancreas. GLUT4 is the one which is responsible for the circulating insulin as well as for the exogenous insulin. As you can see, previously all these have been asked in the exam already. So this is usually something that you don't give much importance, but this is asked in the MCQ, especially in the part 1. GLUT5 is located in the gut. It is apical portion of the enterocyte. Entry of fructose into the cell. So fructose is GLUT5. From glycemic index, what are the questions that can be asked? So what is glycemic index? Glycemic index describes the capacity of the food to raise blood glucose compared with glucose in normal glucose tolerant individuals. High GI index means 70 or above, and low means less than 55. These are values which you need to memorize. And what are the examples? These are the examples. High GI are the white rice, baked potato, white bread. Things that we believe will make us fat once we eat and more of them. And low GI are the opposite ones, which you usually intake if you want to, get slim. Fruits and vegetables and peanuts. White rice, baked potato, white bread. As you can see, brown rice has got a lower GI value. That is why many people eat brown rice routinely, because it has got a lower GI. So high GI means, as you all know, increased risk of obesity, also increases the risk of type 2 diabetes mellitus. That's why we are discussing this in today's class. So next, this is the diagnosis of diabetes basically. So one is this this is the diagnosis of your metabolic syndrome. So one is insulin resistance plus two of the followings, that is high blood pressure, dyslipidemia, central obesity, microalbuminuria, these things. And how exactly do we define these things? Insulin resistance plus two of the followings. Blood pressure is high, dyslipidemia is there, central obesity, microalbuminuria, and these things. And how do we define central obesity? Waist is to hip ratio more than 0.9 in males, more than 0.85 in females, or a BMI more than 30. This once again has repeatedly been asked. Another thing that is asked is definition of dyslipidemia. Triglyceride value more than this, HDLC value less than this for males, for less females. These things, unfortunately, you guys have to remember the values. The concept, I think everybody knows. There is so insulin resistance is a must. Along with that, any two of these things are enough. So that is how we diagnose metabolic syndrome. And how do we manage this? Aggressive lifestyle modifications, long-term exercise upregulates the expression of GLUT4, and orlistat. As we know, this is a medicine which has come, which is basically an inhibitor of GI lipase inhibitor. So what is impaired glucose intolerance and what is pre-diabetes? Let's see one by one. Impaired glucose tolerance means a fasting plasma glucose, that is FG, less than 7. And however, the OGTT, that is the oral glucose tolerance test, 2-hour value greater than or equal to 7.8 millimoles per liter, but less than 11.1. Once again, these values you need to know. So FBG, fasting blood glucose, less than 7, but a OGTT value greater than 7.8, less than 11.1. Greater than 7.8, less than equal to 11.1. This is due to muscle insulin resistance. Patients with impaired glucose tolerance are more likely to develop type 2 DM and cardiovascular disease. Identification of patients with prediabetes, all adult age 40 and over, especially people are South Asian and Chinese descent of this age group, and with this any of these comorbidities. These patients should be assessed for diabetes or impaired glucose tolerance. Okay. This is again a chart which has been given, which is normal fasting glucose value, pre-diabetes and diabetes range, 2-hour glucose oral OGTT, as we discussed, 7.8 is the cutoff and 11.1 is the cutoff for diabetes mellitus. And HbA1c, as we know, 6.5% is the cutoff for diabetes mellitus. 6 to 6.4% is pre-diabetic range. So how to manage type 2 diabetes mellitus? Okay, so management is after this. So these are some of the MCQs. So atypical antipsychotics are most well known as the cause of impaired glucose tolerance. Both typical antipsychotics and drugs like thiazides and beta blockers are also associated impaired glucose tolerance. And this question again, as I told, the values you need to remember, okay, because these questions have previously been asked. So this chart, these values are very important. The values, unfortunately, you need to remember, and also these values for the diagnostic criteria. So this is diabetes mellitus type 1. So we won't go into these things, but we shall see this, the presence of autoantibodies. There are some autoantibodies which are associated, especially if the familial risk, if the both the parents have type 1 diabetes mellitus, if one identical twin has type 1 diabetes mellitus, these are more chance. If a sibling has it, then it is 5 to 6%, which is not that high. And HLA-DR4 is maximum associated with type 1 diabetes more than DR3. So DR4, DR3 both are associated. DR4 is associated more than DR3. Type 1 diabetes mellitus is an autoimmune condition. So it can be, as we know, one autoimmune condition can be associated with the other autoimmune conditions as well. So celiac disease, Hashimoto's thyroiditis, primary adrenal insufficiency, all these we can consider in presence to type 1 diabetes mellitus also. Sorry. So for diagnosis, we need a presence of fasting glucose more than 7 moles per liter on at least 2 occasions. So a single diagnosis is not enough, at least 2 occasions needs to be there. Symptoms of hyperglycemia and a random plasma glucose more than 11.1. HbA1c more than 6.5% is also another answer. So once we diagnose type 1 diabetes mellitus, so what do we need to do? Basically, we need to check the C-peptide level. Why? Because an increased C-peptide levels indicates insulin resistance, also indicates hyperinsulinemia. So it may be type 2 diabetes. However, if the C-peptide level is low, that indicates a more possibility of type 1 diabetes. So differentiation between type 1 and type 2 is used. But clinically, of course, it can be done. A young patient, thin patient, more likely to be type 1, especially with a family history, or with other autoimmune diseases. But patients, elderly patients, I mean a bit old patients and with obese patients, more likely to be type 2 diabetics. And this is very important, the GAD deficiency, GAD antibody, glutamic acid decarboxylate deficiency, found in 70 to 90% of type 1 diabetics. These patients are prone to recurrent infections, and I think you all know the symptoms. For the diagnosis, we have already discussed. So, what is HbA1c? HbA1c is a more than 6.5% in the diagnostic. Between 6 to 6.5% is pre-diabetics. And it should be checked every 3 to 6 months, then 6 monthly. So this is a nice recommendation. So again, you need to remember this. Falsely high HbA1c levels can be seen in vitamin B12 deficiency or folate deficiency anemia, and also in splenectomy. And falsely low values can be seen in disease like chronic hemolysis, patients who are treated with iron, vitamin B12, sudden weight loss, alcohols, advanced CKDs, these things. Among them, this has been asked. This has still yet to be asked, but it, as you know, as this has been asked, so this can also be asked any time, point of time. So how do we manage type 2 diabetes mellitus? For that, we need to manage not only the diabetes, but also the body weight, the cardiac conditions, the kidneys. So we need to look after those. And for that diabetes, only diabetes point of view, we need a lifestyle modifications. And usually metformin is the drug of choice. Sulfonylureas have gone down in preference. And finally, we also have got the gliptins. We have got the amides, and fine if the kidneys are okay. And finally, we can also use insulin. So we shall be seeing these in details. So first line drugs are standard release metformin. So aim is for HbA1c or 6.5% or low. Most important side effects are the GI side effects. If these are not tolerated, trial of modified release metformin will be appropriate. Second line drugs should only be added if the HbA1c rises to 7.5%. Among second line drugs, we have got the sulfonylureas, the gliptins, pioglitazones, or the SGLT2 inhibitors. We can use any of them in this combination, or we can use 2 or 3, then it becomes a triple therapy. We can use any of them. Usually, in modern practice, it is usually a pioglitazone and an SGLT2 inhibitor to metformin. Drugs, triple drug combination in a single pill are available. They, since they are single pill, so it increases the adherence of the patient to the therapy. But if triple therapy is not effective, then we consider combination therapy with metformin, sulfonylurea, and a GLP-1, that is a glucagon-like peptide or mimetic. Especially BMI is very high or specific psychological conditions are there. So that is the quadruple therapy. And after this, we will start insulin. So first was metformin. So first is body weight and lifestyle changes. After that, metformin. After metformin, we come to the dual therapy, triple therapy with the other oral hypoglycemics. And finally, we come to insulin. So HbA1c levels remain 7.5% in spite of maximum tolerated oral therapy. You need to consider human insulin. So usually we start with the insulin detamine or insulin glargine. If we are not confident with human NPH insulin, so NICE recommends human NPH insulin, but often it is not available. Then we can use insulin detamine or insulin glargine as well. These are longer acting insulin. Another option is to start both, but both NPH and short acting insulin, particularly if the patient's HbA1c is 9% or higher. This is very important. We can utilize a separate, like two separate bottles, two separate injections, or as a premix, that is biphasic human insulin preparation. For patients who are on these biphasic insulin preparations, further injection of short-acting insulin before meals or a basal bolus insulin regimen with NPH insulin should be given. So for all practical purposes, we usually give a basal insulin and we give a this NPH plus short-acting insulins. Short-acting just before meals. This is what we use in our usual day-to-day life. This gives a very nice control, but it takes longer time. The short-acting ones prevents the sudden rise in glucose after the meals, and the NPH is also main part of the maintenance dose. This actually works very well. We just have to make sure that the patient is very compliant with routine CBG check at home. Otherwise, the chance of hypoglycemia is very much high. Another important thing is that these employment risks, truck drivers or other social or recreational purposes, these patients often they do not want to use insulin outside the home, or they are truck drivers, night workers, where insulin use at that time is maybe not possible. Then consider using triple oral therapy as long as possible. And obviously, after a point of time, if needed, insulin is to be given. So then we can use a sitagliptin or a thiazolidine or with a metformin combination, as I told beforehand. Yeah. So raise proinsulin levels, raise C-peptide levels. These are all associated with type 2 diabetes mellitus and increased chance of cardiovascular diseases. Here, see the question, they have mentioned taxi driver. Immediately, you need to realize that maybe insulin will not be proper from them. So the patient at type 2 DM was on metformin. His HbA1c was 9 and is now 8.5%. So what is the most appropriate? Not insulin here because the patient is a truck driver. So not insulin. So you adding a Second line drug, we are adding a sitagliptin, that is DPP4 inhibitors. Among the drugs also, the pioglitazone is contraindicated in bladder cancer. So this patient had a history of bladder cancer, so you cannot use this glitazone cells. So again, you need to use gliptins. So a bit about metformin. So metformin main mechanism of action is it decreases the hepatic gluconeogenesis and intestinal glucose absorption. The main advantage is it causes weight loss, no risk of hypoglycemia, and it reduces macrovascular complications. The main adverse effect is gastrointestinal upsets, and in exam also they will give that the gastro upsets are very severe. What will you do? You need to stop insulin, or you need to give a sustained release insulin. So there's a sudden rise in, sustained release metformin, so that a sudden rise in metformin level does not happen. So if this happens, so if we need to do a CT abdomen, then the metformin should be discontinued on the day and for 48 hours thereafter. Mainstay of therapy after this is rehydration, and then we can restart the patient again. Sodium bicarbonate is now obsolete. This is an older edition, so this is used. Don't see, this is obsolete. Don't tell this. Just till rehydration, and if required, then hemodialysis. They're basically talking about contrast-induced nephropathy here, CIN. Metformin can cause lactic acidosis, especially if the patient is an alcoholic, and it is relatively contraindicated if the EGFR less than 45, that is in chronic kidney disease. So if the patients are on these agents like glibenclamide, glyclazide, glyphosate, then beta blockers uses should be done with caution, because beta blockers may basically mask the signs of hypoglycemia. Sulfonylurea, in addition to causing a lot of hypoglycemia, there is no advantage of macrovascular outcomes reduction. As we saw, metformin decreases the macrovascular outcome, improves the macrovascular outcomes. Sulfonylurea does not do that. So coming to insulin. So these are the types of insulin. As I was telling, the insulin which you can take just before the meals, rapidly acting insulins as per Lispro. So peak is in 1 hour, onset is in 5 minutes. Reduces the chance of between meal hypoglycemia. So at breakfast time or at lunch time, we can do these things. Short acting insulins are act rapid. Onset is in 30 minutes. Peak is in 3 hours. This is the basal bolus regimen. Basal is this long acting one, determined and glargine, which has got no peak. So see, these are peakless insulins. Peakless insulins. Onset time is around 1 to 2 hours and duration of 24 hours. Determined duration up to 72 hours also. So no chance of hypoglycemia. No chance of hypoglycemia. So this is why you're using the basal. And bolus we are often using the act rapid. In ICU also, we are controlling the diabetes mellitus in ICU as intensivist. So we always use this act rapid along with a bolus regimen. Act rapid plus a basal regimen. That is basal bolus regimen. Act rapid plus glargine is our preferred combinations. And in very few patients, we are using a Lispro just before the lunch. So these are very practical things. So what is the onset, what is the duration, what is the peak? These things you need to know. Which are the rapid acting, which are the short actings, and which are long acting. See, NICE recommends NPH. NPH is the intermediate acting. So this is the first line recommendation, because its onset is in 2 hours, duration is 12 to 18 hours. So it has got some advantage of this, some advantage of this. So it is the intermediate. That is why NICE recommends NPH, isofen insulin, over others. So this is basically a mnemonic, nothing else. You can remember it. Glargine, glutathione, aspartame, Lispro. So at the bedtime, we can use intermediate acting insulin, or in the evening, you can use a long acting insulin. That is a glargine. So you can use the flat dose of 10 units and you can gradually increase it 12, 15, 20 units, something like that. Targets are fasting and preprandial should be between 4 to 7. Postprandial should be less than 10. So this is for hospitalized patients. Similar targets only, basically 6 to 10, just the value is different. So in renal failure, the insulin dose exogenous dose should be reduced by 25% when EGFR is 10 to 50. So as soon as the EGFR becomes less than 50, we need to do 25%. Once the EGFR is less than 10, then you need to do basically half as we do in our routine ICU use. So main side effect of insulin is hypoglycemia, and hypoglycemia. Other than that, strangely, it can cause some weight gain. And of course, hypokalemia. Anybody who has worked with insulin knows we need to monitor the potassium. And of course, if you're repeatedly using in the same cell, lipodystrophy. All of these are very, very frequently asked in the MRCP exam. Part 1, Part 2, PACES, whichever exam you are giving, it will be asked in your exam. And regarding insulin, which insulin to start, which insulin to use here, why not the oral hypoglycemic agents, which oral hypoglycemic agent to start with, when you use gliptins, what will be target blood sugar levels, what is the definition of oral glucose tolerance test, everything will be asked in your exams. Sorry. And this is of course Daphne. Daphne is dose adjustment for normal eating and education. Daphne, very, very, very frequently asked in MRCP PACES, but it can be also asked in part 2 as a simple MCQ. Finally, we are coming to GLP-1 analogs. These are always said in the last in the textbooks or in my slides or when I studied. But exenatide is very, very frequently coming up in our day-to-day use also. 29 তারিখ তো আছি আমি না না 30-31 কনফারেন্স 28 তারিখটা তো ওই ওয়ার্কশপ আছে 29 তারিখ আমার ওয়ার্কশপ নেই তো আর 29 তারিখ আমার সিআরটি ওয়ার্কশপ আছে অ্যাপোলোতেই আছে এই সিআরটি বলছি ব্রঙ্কোস্কোপি আছে 28 তারিখ নেই আমি না পুরোটাই আছে আমি অ্যাপোলোতেই থাকবো 30-31 নেই Sorry for the interruption. Actually, it is a conference which will be going starting from tomorrow, and I'm in the organizing team. So sorry for the interruption. So anyway, exenatide and liraglutide. So mechanism action is it increases the incretin effect, oral glucose load. So there is a increase in the GLP-1 produced by the ileum, causes increase in insulin release, and decreasing glucagon secretion slows down the gastric emptying. So that is why we are using the analogs of GLP-1, and the example is obviously exenatide and liraglutide. Exenatide causes very much vomiting. Liraglutide is given once a day. Liraglutide can be used in renal impairment. Liraglutide is the only drug which is used in this group. Exenatide is not used. Okay. So liraglutide, need to know the name. It can be used in renal impairment. It is given once a day. This is because it is a half long acting drug. And exenatide is no longer in use. Liraglutide is used. So these are the nice guidelines regarding use. The BMI needs to be more than 35, and there should not be any occupational implications of using the drug. It improves the glycemic control, no risk of hypoglycemia, promotes weight loss. Target is a 1% reduction in HbA1c and 3% weight loss after 6 months of use. Adverse effect, pancreatitis. This will be the one which will be asked in the exam. Main effect is pancreatitis. And of course, GI, nausea, vomiting. So the nice indications, the advantages, the goal, the adverse effects, the major complications, these things needs to be used. So when to choose exenatide as an alternative, mostly in when there is a morbid obesity or if there is a risk of hypoglycemia, especially in the HGV truck drivers. So these are the indications, main indications for choosing exenatide or liraglutide over not exenatide. Okay, now everybody is using liraglutide. It is a GLP-1 analog over insulin. Otherwise, you always use insulin. You don't use liraglutide. But if the patient is very fat, we could not call people fat. If the patient is very much obese, BMI is more than 35, and the occupation implication, and we are using it. Please go through these things before appearing in the exam, because these will be asked. This is why I made a separate class for the. This is why I made a separate class for this, and I'm discussing the individual drugs also. I know I'm going a bit fast, but if I go slow, then it will take 2 more classes, and that many classes unfortunately cannot be given for the exam. I mean, for one topic. So once again, DPP4 inhibitors, what are they? They are same things. Incretin effect, same L cells of the ileum, GLP-1 degradation via the enzyme DPP4. So GLP-1 we need for insulin production. So here these are analogs, GLP-1 analogs. Here these are DPP4 inhibitors, because DPP4 they decrease GLP-1. So we want to decrease the DPP4. DPP4 inhibitors, incretin mimetic drugs, they increase the insulin secretion by increasing the GLP-1 levels. The examples we know, these sitagliptin and linagliptin are commonly in common day-to-day practice used every day. And the main indications are, see, there are some that they commonly consider the monotherapy also, but you're usually not using it as monotherapy. You are usually using it as a combination therapy with the metformin. So it is only recommended as a second-line therapy metformin if patients have a significant risk of hypoglycemia, or if sulfonylurea is not tolerated if they're already using. Okay. NICE guidelines suggest that DPP4 inhibitors are preferable with thiazolidines if further weight gain would cause significant problems. A thiazolidine is also contraindicated, or the person has a poor response to thiazolidines. These are some of the indications of the gliptins. And target is only the reduction of 0.5 percentage points in 6 months. So I don't know whether if any one of you are actually treating diabetes patients, but if you are using the DPP4 inhibitors along with the metformin diabetes patient and you are checking the HbA1c after 3 months, you will see there is a 2 to 3% fall. Okay. So I have given at least 200 plus such prescriptions for DPP4 inhibitors. Since I am an intensivist, so I am not. So that 200 plus is not a very good number for diabetes patients, because through diabetology, endocrinology, they give this almost weekly 200 plus prescriptions. But since I am an intensivist and I only see patients in the ICU and in the OPTs, so my prescriptions are a lot lower. But still, I have given to at least 200 plus patients, and in almost all of them, the reduction after 3 months of HbA1c drop was around 2 to 3%. So there is a massive improvement in these patients. So DPP4 inhibitors and thiazolidines, these these are very, very useful drugs. Now you are coming to the sodium glucose cotransporter 2 inhibitors, the gliflozins. Once again, empagliflozin, dapagliflozin. These are not only have got an effect on the diabetes, but also on the heart and the kidney. They are reversible inhibition of HGL2 in the PCT of the kidney. They cause glycosuria and polyuria. So, if the patient is suffering from a UTI, if the patient already has got a glucose in the urine, if the patient is known case of diabetic ketoacidosis, then we cannot use this drug. These are all contraindications. And this is how the question will be asked in MRCP exam as well. That these things are present, what will you do? This is one bad thing. The good thing is that these drugs also has been shown to reduce cardiovascular mortality. So that is why these things are becoming so common. Similarly, another good thing is it promotes weight loss. Like most of these drugs causes sodium loss, fall in blood pressure, reduces the risk of cardiovascular mortality, as I said, and does not usually cause hypoglycemia. Also reduces uric acid. The main adverse effect is recurrent UTI and genital infection, vulvar infections, and decay also. Diabetic ketoacidosis, recurrent thrush, recurrent UTIs, increases total cholesterol, causes acute kidney injury.
Good evening, we are stuck in traffic. పంపించింది resistant time behind it.
So this is, please mute yourself. So this is the problem with canagliflozin, which increases the risk of lower limb amputations and fractures. This is why that is why empagliflozin or dapagliflozin, DAPA is the more commonly used drugs in my day-to-day practice. Very good agent, but you need to ensure that the patient not having AKI, patient not dehydrated, and the patient doesn't have any infections, patient not no UTI, no decay. These are the 4 or 5 contraindications of using it. It also reduces. It is also very good drug for heart failure. Acarbose, miglitol, these use of the agents have come down. They are mostly the alpha glucosidase inhibitors. Just remember the name. I don't think it will be asked in exams now. So next you have come to diabetic ketoacidosis. So for diabetic ketoacidosis, what we need to know, there can be abdominal pain, dehydration, small respiration, that is fluty breath, serum sodium is falsely low, and there can be a precipitating factor like sepsis, trauma, cardiac, AMI or a CVA, these sort of things. Diagnostic criteria, again the values you need to know: 11, ketones more than 3, bicarbonate less than 15, pH less than 7.3. Severity assessment, GCS, oxygen saturation low, low blood pressure, pH less than 7, blood ketones more than 6, potassium less than 3.5, anion gap more than 16. All of these are bad prognostic factors. Main differentials are other causes of ketoacidosis like alcoholic ketoacidosis and starvation ketosis. The main management is fluid replacement, insulin therapy, and potassium replacement. For fluid replacement, we need to replace around 5 to 8 liters of fluid. For insulin, 0.1 units per kg, loading for 0.1 units per kg per hour. Correction of hypokalemia also need to give. You need to check the potassium before starting the insulin. If the patient already has hypokalemia, then you need to replace the potassium first and then correct the insulin. Then give the insulin. Assessment of treatment target is reduction of blood ketones by this value, increase the venous bicarbonate by 3, and reducing the capillary blood glucose by 3. So all these values for diabetic ketoacidosis need to remember, because these will be given into and will be asked whether the management is proper or whether you need to further resuscitate or increase the dose of ketamine. Increase the dose of insulin. What is euglycemic decay? Euglycemic decay can actually be caused by the SGLT2 inhibitor drugs, dapagliflozin and the canagliflozin. That is why it is contraindicated in decay. As I told previously. Main treatment is initiate glucose 10% straight away. Begin with this insulin rate, and if glucose is falling despite the glucose, then you need to avoid hypoglycemia, and they need to get an adjustment between the glucose and the insulin you are giving. So main complication, the main cause of death is cerebral edema in decay. Besides that, there can be thromboembolism, ARDS, and recovery in decay also risk of hypophosphatemia. All of these are previously asked questions. Some also very practical questions in your day-to-day practice, also ICU practice. So what is hypoglycemia? Hypoglycemia definition, it is less than 3.9 millimoles per liter or less than 70 milligrams per DL. So main cause is insulin related or hypoglycemic agents related. In non-diabetic, it can be insulinomas, gastric bypass surgery, any critical illness, there is sepsis-induced organ failure, liver failure, hypopituitarism, alcohol, autoimmune causes like insulin autoimmune syndromes, and drugs that cause hypoglycemia are non-selective beta blockers. So the main feature is Whipple's triad, that is a low plasma glucose, signs and symptoms of hypoglycemia, and relief of symptoms when glucose is given. And the main features are neurogenic or neuroglycopenic. So if the Whipple's triad is not confirmed, no further workup is indicated. In diabetic patients, hypoglycemia is always due to acute illness or missed medications, and further work is not indicated. Otherwise, we need to check the C-peptide levels and insulin levels. If both are raised, it means the patient taking more insulin, endogenous insulin secretion. And if insulin level is raised but C-peptide levels are low, then it means it's insulin abuse. So insulin levels will be high in both, obviously. But if C-peptide level is low, that means there is a exogenous insulin. And if C-peptide levels are high, it means endogenous insulin. So we need to take a plasma sulfonylurea screening, and depending on the result, further investigations. So what is hypoglycemia unawareness? hypoglycemia unawareness means this neuroglycopenia symptoms will not be not be reported by the patient. So main mechanism is recurrent hypoglycemia, inability to recognize impending hypoglycemia by symptoms because there is failure of the counter-regulatory hormones. The tachycardia, tachypnea, sweating, a feeling of dizziness, headache, all of these features all diabetic patients know because they do get hypoglycemic at some point of time. So they usually tell it. But often there is a failure of the autonomic failure. That is why these parasympathetic, these counter-regulatory hormones are not secreted. That is when the problems start. Alcohol inhibits gluconeogenesis, decreases peripheral hypoglycemic responses. Once again, can cause this. The main treatment is optimize the insulin treatment, avoid hypoglycemia in adults with type 1 by offering insulin pump and real-time continuous glucose monitoring. Nice advices to avoid relaxing individual blood pressure targets. And patient demonstrating hypoglycemia unawareness required to stop driving. So this is very important. It's actually medical legal because this needs to be like written in a doctor's prescription. There's no driving. And we shall discuss in today's class also DVLA. So initially the patients are given an option to report. If they fail to report, a doctor can also report. So diabetes mellitus and hypertension, just one slide I have kept. It is a topic on itself. The first line drug are the ACE inhibitors. For African or Caribbean family group, ACE inhibitors plus a calcium channel blocker. For a woman, a calcium channel blocker can be used. Targets are NICE recommends the following the blood pressure targets for type 2 diabetes. If no end organ damage, less than 140 by 80. If end organ damage, less than 130 by 80. So 140 by 80 for all, 130 by 80 the target if there is end organ damage, most commonly renal or retinal damage. So I have started with diabetic neuropathic arthropathy intentionally because usually we are also discussing about the cardiac complication, the retinopathy, and the neuropathy gets neglected. But today we shall discuss neuropathy in a bit details, and we shall, you can tell, neglect a bit of the others because the others will be discussed also. But neuropathy we shall be discussing some details. So a red hot swollen foot should raise suspicion of Charcot neuroarthropathy. These are typical part 2 MRCP questions. This will be given as a, there will be 7 to 8 line question, and in the middle of it, 4th or 5th line, you will mention this red hot swollen foot, and that will be the clue. And then if you take up the clue, it will take you 5 seconds to pick up the answer and note it down. Otherwise, you will think of something and then finally give a wrong answer. So the most common cause of diabetes mellitus, it occurs secondary loss of sensation. Pathophysiology is multifactorial, but as we know, there is a Charcot joint. The pathophysiology actually not be asked, but there is both autonomic neuropathy and peripheral neuropathy. So lack of pain sensation, increased small injuries, ultimately resulting in increased osteoclast activity. Main features, as I told, swollen red warm joints. 75% patients report some degree of pain, less painful than expected. So if you examine, you'll see that the area it is swollen red hot, but and somewhat deformed. So you expect very painful, but it will not be painful because of the nerves are already damaged. So the pain sensation is felt by the patient, and that is the reason why these small injuries over months, over years is causing this severe damaged feet called Charcot joint. So the management is mostly clinical diagnosis. Basically, you can do a indium level white cells scan also, and treatment is surgical referral, regular dressing, and surgical referral mostly, and making sure that some special shoes are available, soft shoes, never to walk barefoot, always to apply some cream or moisturize the lower part of the feet before going to the bed. These simple remedies, mostly for MRCP patients, this, but the question with the pictures or the clinical question can be asked in part 2 also. Once again, another pictorial question. We have I shall show you the picture at the end, okay? So it basically begins as a patch of erythema, which then ulcerates. This yellowish shine, this is always given in an MRCP exam if the answer is this. Without this, almost never the answer will be necrobiotic lipodega diabeticorum. Yellowish color to the sheen. or shiny shin. That will be the typical answers. Treatment is topical steroids and a support bandaging, definitely. Don't worry, we should discuss the hypertension also. Just giving the image of hypertension first. So, in hypertensive retinopathy, why did I show it first? See, these are the typical clues. The flame hemorrhages, dot blot hemorrhages, cottonwool spots, blooding of the optic disc. Okay. Some of these findings are also seen in diabetic eye diseases, but the hard exuders and the venous bleeding, these are absent. So these findings, which you commonly associate with diabetic and hypertensive retinopathy, these are common in both. But the hard exudates and the venous bleeding, these will be common in the diabetic changes, who are not so common in the hypertensive changes. So what do we see in diabetic retinopathy? Diabetic retinopathy, about 80% of patients with type 1 diabetes will have some retinopathy after 10 years. It causes rapid worsening, most common cause is pregnancy, rapid improvement in blood glucose. So strangely, if you are a smoker with type 1 diabetes, then your chance of diabetic retinopathy is very much high, as expected. But if you are a smoker with type 2 diabetes, then the chance of diabetic retinopathy is low. So this has been published in 2008 meta-analysis, and for some reason, NICE really wants to differentiate between these two. So very commonly asked this thing in the exam. So you only have to remember the new classification. It is mild, moderate, and severe. Mild type. In mild, there is microaneurysms. In moderate, there are dot blot hemorrhages, hard exudates, venous bleeding, looping, cottonwool spots. And in severe, there are blot hemorrhages, microaneurysms, ARMA. ARMA is intraretinal microvascular abnormalities in at least one quadrant, venous bleeding in two. So as we saw here, it is the hard exudates and the venous bleeding, which are typical of diabetic retinopathy. So venous bleeding will be seen in at least two quadrants if it is a severe one, and hard exudates will be present moderate. Microaneurysms will be in mild ones only. So dot blot hemorrhages, hard exudates all moderate, and ARMA in at least one quadrant, venous bleeding in two quadrants, blot and microaneurysm 4 quadrants will be severe. Once again, you need to memorize this thing. If non-proliferative diabetic retinopathy, which was the previous classification, mild NPDR is this thing, moderate and severe. So how do we manage this? Regular observation and mostly this laser photocoagulation. Observation, photocoagulation. What is maculopathy? Maculopathy is macular edema is a common form of maculopathy. Occurs when there is abnormal leakage and accumulation of fluid in the macula. There is also retinal infiltration of lipids in fluids causing macular edema. So diagnosis is a fluorescent angiography, and management is you have to routinely go to an ophthalmologist for visual acuity check, and ultimately you can go for laser treatment or VEGF inhibitors injection. So treatment of maculopathy. Regular checkups and laser treatments and VEGF inhibitors. So patients age 12 and over type 1 or type 2 diabetes, screening should be offered to everybody. For diabetics, a low risk of side law 1 year, 2 years. For those are once a year. So anybody who is age 12 and over type 1 or type 2 diabetes, they should be given the option of routine eye screening. And if they have got an eye disease of eye vision loss is more probable, then once yearly follow-up. If not, either once yearly or it can be 2 yearly follow-up also. Treatment, as we saw, indications for emergency referral to ophthalmology very important. Sudden loss of vision, rubeosis iritis, the iris will very much red and with red blots. Vitreous hemorrhage, retinal detachments, pretty obvious indication for urgent referral to an ophthalmologist. Emergency referral, sorry. Urgent referral, that is within 1 week. Vitreous hemorrhage, proliferative retinopathy, and hard exudation in the macular region. Prognosis, 50% of those with proliferative retinopathy will have an irreversible loss of vision in 5 years if not treated. This we saw. Next is diabetic retinopathy in pregnancy. There is a higher chance of deterioration of this patient if they are pregnant, so 3 monthly checkup is required. So I hope this is clear. This will be asked in the exam. Hard exudation, venous bleeding are typical for diabetic, not for hypertensive. Then that is how to differentiate between those two in the exam also. So symptoms and signs of distal symmetric polyneuropathy. Large myelinated nerve fibers, their main function is pressure, balance. So symptoms will be numbness, tingling, and poor balance. Ankle reflexes will be absent, and proprioception will reduce or absent. But if small myelinated nerve fibers, then the main sensation is the burning, electric shock, stabbing like pain. Pinprick sensation will reduce or absent, and hot cold discrimination will reduce or absent. So basically something which we are more so often neuropathy pain, they tell that it is a very stabbing pain or electric shock like pain that is typical for small fiber disease. In these conditions, pinprick sensations, hot cold sensations will also be reduced. Large fiber involvement in neuropathy results in reduced proprioception, light pressure, and vibration sensations, and is the earliest clinical identifiable feature of peripheral sensory motor neuropathy. And short fiber is a later manifestation. So which goes early? Large fibers. Which are once are lost, pressure, balance, numbness, tingling. These are, pressure, balance are lost, vibration sensation is lost, poor balance, in terms of falling down. Ankle reflexes are absent. This occurs earlier than the small neuropathies. As you can feel, any one word can be given and asked in an exam in MCQ. So just go through these parts, okay? This is pharmacotherapy for painful diabetic neuropathy. Just a few drugs you remember. Firstly, the group of drugs, SNRIs, that is serotonin norepinephrine reuptake inhibitors, TCS, tricyclic antidepressants, and also the gabapentin group of drugs. So the examples are pregabalin and gabapentin, amitriptyline, nortriptyline, and the duloxetine, venlafaxine. The difference with neuropathic food and ischemic food, blood supply has gone, so it will be cold, there will be resting pain, nearly pulseless, ulceration often painful, gravity dependent reddening. And neuropathic often warm, painless, pounding pulses, ulceration mostly on the plantar surface, that is the behind the foot, okay? It can be high arch to procloin, gravity dependent and high arched. I think these warm, cold, painless, painful, ulceration on the plantars and painful ulcers in the heel areas. These I think everybody knows, right? So that is the difference. And once again, all of these are MCQ questions. Autonomic neuropathy we have already discussed. This we have discussed. This is, as I told, the picture of necrobacil hypotheca diabeticorum. Yellow shining thing on the sheen of the foot in long-term diabetics. Yeah. So coming to once again to the DVLA part. Sorry. So if they are type 1 vehicle drivers and are on diet control alone or on oral hypoglycemic agents, no need to modify. If on insulin, if they are aware of hypoglycemia, that is, they can understand when they're getting hypoglycemic. Not more than one episode of hypoglycemia recording the assistance another in the last 12 months. No relevant visual impairment. Then you can allow them to drive. But if they're type 2, they need to meet a set of criteria. So they always need to go through DVLA. And if the patients are hypoglycemically unaware, in group 2, they simply cannot drive. So they will be refused or revoked the license. In group 1, they must not drive and must notify. Driving may resume after clinical report by the GP that hypoglycemic awareness has been regained. So this is the ones who have got impaired awareness. But if they're aware of the hypoglycemia, in group 1 drivers who had more than one episode requiring the assistance of another person while awake in the last 12 months, they must not drive and should inform the DVLA. Group 2 drivers should not drive. Severe hypoglycemia driving, all group 1 must not drive. So this is one set of questions can be asked. This is second set of questions can be asked. This is third set of questions can be asked. Impaired awareness, group 2, no driving. Group 1, no driving, but they can regain the license if the GP goes. If the GP goes in favor once they have been controlled. But group 2, the license will be revoked. So that is the end of the career as that. So it is very, very, very important, and often they refuse that and those accidents happen. This is life threatening, this is illegal, and I mean giving more stress to this because these are very important MRCP cases. But in part 2 also this can come. This will not come in part 1. Don't worry. Those who are giving part 1 don't know if anybody is giving. But for those who will give part 2 or who will one day appear for cases, this is probably the most important part of your exam. I mean, part of your communication session if they ask you about driving. I hope I have underlined the importance of this part enough. These are similar things. Just need to go through the DVLA guidelines. Okay. So now coming to some last 3-4 topics which often comes up in the exams. So what is insulinoma? Insulinoma is a tumor arising from the beta cells of the pancreas. 90% are benign, 10% are malignant. Insulin plus C-peptide levels during a hypoglycemic episode with the high C-peptide levels and raised proinsulin to insulin ratio. High C-peptide levels, as you told, it means that the patient is generating endogenous insulin. So there is something which is producing insulin. So most common cause is insulinoma. And the C-peptide is low and insulin is high. That means the patient is taking extra insulin. Either the patient is being given an overdose of insulin or they're taking insulin on their own. The main differential diagnosis for insulinoma is sulfonylurea misuse, because similar findings will be there, but either there will be history or you can check the serum levels of the drug sulfonylurea. That is how you differentiate. So if there is a insulinoma, surgery is a treatment of choice. Otherwise, we can use diazoxide with the potassium channel activator. This is the glucagonoma. The characteristic figure 6D is decreasing weight, diabetes, dermatitis, diarrhea, DVT, depression. A patient with a skin rash, with depression, with diabetes, and decreasing weight, always rule out glucagonoma. Although less common than insulinoma, but this rash is very typical. The rash is very typical. Okay, do see these images on the internet. Or today also, if we at the end of time, we can just share my net and we can see all together the 3-4 images. This necrolytic migratory erythema is a rash that I am talking about. Most common symptom found in 70% cases, red blistering rash starts in due to erythema, located predominantly on the face, perineum, and lower extremities. So what is MODY? MODY, there are basically it is the autosomal dominant disease. There is lack of autoantibodies. Differential diagnosis is the diabetes mellitus type 1, where there will be autoantibodies. Which autoantibodies? The GAD autoantibody will be present in type 1 diabetes. Here, these will not be present. No antibodies here. Strong family history, non-obese. There are several types. MODY3, which is the commonest form. This is a gene responsible. Particularly important to diagnose, many patients initiated insulin can in fact be managed with sulfonylurea. MODY2, 20% of cases. Second commonest, glucokinase gene deficiency, defect. These are type 1 and type 5. Type 5 is renal C, that is why it is an MCQ. Defect is in this gene. And in type 1, third commonest, so pretty rare. Treatment is sulfonylurea. Treatment is insulin usually necessary. And here again, sulfonylurea. So drug of choice for MODY type 3, which is the most common form, is sulfonylurea. Sulfonylurea. This is the only disease related to diabetes, so sulfonylurea is a drug of choice. Two is second most common. It is also 20% of cases. It is GCK gene. Now, genes are asked, that is why I am telling. Next is the LADA, latent autoimmune diabetes of adulthood. Diagnosis is by GAD autoantibody test. Features are consistent with type 1 diabetes, that is weight loss. In contrast to type 2 diabetes, patient typically younger without an increased body weight. In contrast to type 1 diabetes, insulin not usually required. Management, sulfonylurea should not be the first line in LADA. That is why it is very important. This will be asked in the exam. No sulfonylurea here. In MODY, sulfonylurea is a drug of choice. Mitochondrial diabetes, once again, very difficult to diagnose this from others. Discriminated from the MODY by presence of maternal transmission, bilateral hearing impairment. So audiometry is needed. Mitochondrial disease, M for mitochondrial disease, M for mother, and audiometry is needed. So try to read this the way I'm telling. Don't try to read the whole thing. It will be very difficult to remember. And the third M is metformin, which is contraindicated here. No metformin. Okay. So M for mitochondrial disease, M for mother, M for metformin, but contraindicated. And do audiometry. Bilateral hearing impairment will be there. Genetic analysis is not important here. But genetic analysis of these MODY and these LADA, these things are important. Last part of today's presentation is gestational diabetes mellitus. Diagnosis is a fasting glucose more than 5.6, poor glucose more than 7.8. If fasting glucose is between these two levels, proceed for 77 grams oral glucose tolerance test, OGTT. So investigation of choice remains OGTT. Main complication is macrosomia. There can be the shoulder dystocia because the patient babies are so large, so common delivery problem. Besides neonatal hypoglycemia, maternal complications are hypertension, preeclampsia, increased risk for developing diabetes mellitus cesarean delivery. Because of increased risk of cesarean delivery because of the macrosomia. So main management is you need to give aspirin, you need to have a diet. If fasting level glucose level less than 7, trial diet and exercise. If not, then we can start with metformin and later insulin. So the usual treatment. If first diet, then metformin, then insulin. Nothing extra. If the patient has got a pre-existing diabetes in pregnancy, then there should be increased frequency of retinal screening. Treat retinopathy as it can worsen in pregnancy. Stop oral hypoglycemic agents. Folic acid should be given. Aspirin should be given. Detailed anomaly scan at 20 weeks, including 4-chamber view of the heart, and it should be a planned pregnancy. This folic acid, oral hypoglycemic agent stop, and anomaly scan and retinopathy treatment and the follow-up. These things are the ones which are usually asked in the exam. So that is all for today's presentation. It was a bit hurried, I know, but if you want, I can share the slide or something like that. And like you can like reach me on this email address. Or you can also contact me over this if any doubt over endocrinology is there. This is my personal phone number, WhatsApp number. So you can contact me either on the email or on this number. Or of course you can contact me via Farz Academy also. All the best, and this was my last class till I get another opportunity to present another topic. I think I shall, and I think people are already leaving, and that's okay. But I really hope that you study endocrinology because endocrinology is huge and lots of questions will be asked. So do study endocrinology in details. No questions, and it's already late. I don't think anybody will ask me any question, but you can reach me either through Farz or through my shared mail ID and phone number. Thank you for today's opportunity.
Thank you, sir.